Hi, welcome to Endometriosis A to Z for all stages and all ages. Today, I'd like to welcome Dr. Griffith, Dr. David Griffith. He is a consultant gynecologist from the UK. He has 25 years of experience seeing patients in London to the southwest of England, and he consults for international patients and those who need a second opinion. His specialist interests are menstrual disorders, pelvic pain, and endometriosis. Welcome to our podcast.
Thank you very much, Carolyn.
Wonderful to have you, David. And I think there's another. David is one of the great innovators in the UK. I want everyone to be sure to know that. I like to toot other people's horns for them, and specifically with regard to diagnostics, and especially with regard to the young, the adolescents, the teenagers who suffer from endometriosis. I think David is one of the bright lights there in the UK, and was one of the earliest who saw the value of the introduction of the EndoSure test as an early diagnostic test. And I'm going to let him elaborate more about that as we go on.
Dr. Griffiths, how long have you been using the EndoSure test in your clinic? And are there any other tests that you're also using for early evaluation or early diagnosis?
I started off using the Zigwig test because that was very promising, and it was really came out before the EndoSure, but the Zigwig test had some initial problems and it was withdrawn from service for several months. And then I was at the conference for endometriosis in Edinburgh in 2024. And I saw the EndoSure test and I realized this would be a boon for our patients, because that's one of the problems. We see patients from as young as 14 with endometriosis, but as we all know, it can take 7 to 8 years at least to get a diagnosis. A lot of the patients are just normalized and were told that it's just normal period pain. They'll grow out of it or get better when you get pregnant. Interesting, the number of patients come to me really upset for a second opinion because they're told by their OBGYN that, go and get pregnant, have a pregnancy. And that's the last thing they want to do. They just want to get better. And I've got daughters myself, so I know exactly how they feel. So having the EndoSure test for an early diagnosis is absolutely great news. We've not seen any real movement in the treatments and the diagnosis for endometriosis for like 2 decades, and now it's all seems to be coming together.
That's actually something we have in common. We each have teenage daughters, the exact same age. I've got 3 female teenage daughters. So one of them certainly has endometriosis, and the EndoSure was really easily and quickly able to give us information to that. That doesn't mean her gynecologist necessarily recognized the test here in Alberta because it's very new here. So I'm just wondering for any professionals listening, what is your experience with this rapid diagnostic technology? Has it worked? Has it been well received by the NHS? Where are you in the UK with this technology?
So in the UK, there are a few NHS hospitals who are trialing it, and they're going to put it through trials. But with the NHS, everything moves fairly slowly. But I was lucky enough to have a practice where I have quite a large private practice. And patients are willing to pay, but also the UK team who provide the EndoSure test came and saw a lot of NHS patients for me. So we did a trial. The patients I initially put forward, the ones clinically I thought they had endometriosis, and they all were positive with the test. Some of these patients were naive, i.e. they weren't on any hormonal therapy at all, and the others were on hormonal therapy. And what we've been doing for those who are positive on the test on hormonal therapy, we didn't test them again. But those who were naive, as in they weren't on taking any hormone therapy, I started on hormone therapy and we're testing them again. And not only do we see a subjective improvement, but objectively, the severity score comes down as well. The new drug called Rieco, I'm not sure if it's available in North America yet. It's only just become licensed for endometriosis and adenomyosis in the UK in July last year. But I've been using that for probably about 12 months. And I've had numerous mothers say to me, it's been a complete game changer for their daughters. So if they have a positive test, I'm now offering patients re-echo if they've tried other hormonal therapy first. And the advantage of re-echo is they can stay on that for long term. Whereas previously we were giving them drugs like Prostat, Dectapeptyl, and the license for that is only 6 months. Often we'd give it for younger women for 2 years, but after that you have to be very wary because of the potential risks of bone thinning. So now with the new Endometriosis test and the new drugs, the course of treatment is going to be very different to that of their mothers.
That's so exciting that you're doing that work. So you said you did some clinical trials. Have you been able to publish those? Are you looking to
No,
publish or?
what we're going to do is we're getting a cohort of ladies who were naive to begin with, and then we put them on re-echo. And we're going to retest them in 3 months. And we've got about 8 to 10 patients so far. And then we'll publish that.
And so one of the things that you mentioned was the activity score. So not only does just for our listeners, the Endometriosis test gives a yes or no for detection of endometriosis, and it gives an activity score between 0 and 1.0. And so basically, just to rephrase, you actually saw people's activity scores drop objectively, but you also saw their symptoms subjectively improve.
Yeah, I found there was one lady, she'd actually been on the mini pill, and she didn't like the mini pill because all the ladies do get side effects with progesterone, and a lot of the young girls have mood changes. So she'd tried that, and she was on that when she had the test, and she had quite a high score. And this was a young girl, 15, not sexually active. Her parents had bought her a TENS machine. A TENS machine is for pain relief. She was using hot water bottle, missing school. And in the UK, the gold standard is really doing the laparoscopy. But I've got a 16-year-old daughter myself, and there's no way I'd let even my best colleague do a laparoscopy on her. We'll probably come back to that later on. But so she had the test. It was positive. I put her on re-echo. We did the test again, and the index score came down. Her mother was one who said it was a game changer. Interestingly, because it wasn't licensed in the UK at the time, her mum had some concerns, so I put her back on the combined pill. And then 3 months later, the mom came back to me and said, "Oh, can we go back to re-echo? Because it doesn't work as effectively." So she's now on re-echo again.
Yeah.
So, I mean, when these young girls, talking about laparoscopy, when you do laparoscopy in a young girl, not only are the inherent risks of surgery, but a lot of time you don't see anything. Certainly what happens in the NHS, you may not get the right person doing the test. But very early endometriosis is often missed. Certainly in the past, I remember operating on 16, 17-year-olds and not finding anything at all. And yet you scope them again in 2 years' time, and the disease is quite prolific. And often with very minor disease, it can be very difficult to see.
So do you see this test has a role in predicting who you would take to surgery or who you would send to imaging studies? Where do you see the value will be for that adolescent population?
I think getting an early diagnosis is really important. There was a lady in the press in the UK recently. She was 24, and she'd come to the fore because we got a program here called Traitors. And she was diagnosed at 24, and she got significant disease. And now she's waiting for surgery, I believe. But a lot of these young girls are seen by their primary care physician, and their symptoms are often normalized. If they are sent for a scan, more often than not, the scan doesn't show anything because it won't pick up minor disease. It'll only pick up sort of stage 3 and stage 4 disease. Often ladies are diagnosed with chronic fatigue. There are other ladies are misdiagnosed as irritable bowel. And often as a primary care physician, because I sometimes work in primary care, it's difficult if you don't have the knowledge of what to do with these young ladies. But if you had this test in primary care and get a result straight away, or within half an hour doing the test, then you know which direction to send the patients. If the patients are responding to hormonal therapy and there's nothing on the ultrasound scan, I would not advocate surgery. I would only advocate surgery if there was something on the scan or they didn't respond to hormonal therapy.
Mhm.
So do you think that a test like this belongs in the primary care hands to facilitate, therefore, the referral up to the consultant level where you sit?
I do, yes. Well, it's very useful in secondary care because you need to do lots of research and patients can have it prior to surgery and after surgery to see how successful the surgery has been. But as a primary diagnostic tool, it really needs to be in primary care. Whether it's done in the community in special centres rather than in individual surgeries. A bit like you go to the radiology centres to get your X-ray or your CT scan or your MRI. You could go and have your ECG at different places. You could go and have your Endosure test. In fact, we've set up a clinic in Manchester, which is like north of England. And we have colleagues up there and some patients just go along for the test. And we then offer them a consultation extra if they want to. And it's beginning to work really well. Some patients just want to know because they've been seen by their own OBGYN, thought to be endometriosis. They're put on the waiting list for surgery and they're not sure whether they want surgery or not. But when they've had a positive test, it reaffirms that this is probably what they want to do. When other ladies are not so sure, and they will have the consultation first. And obviously, if the test is negative, then they're relieved with that.
Yeah, and they know to start looking for something else because it does just eliminate it. Sometimes when you have symptoms and they're unexplained, it does help eliminate something that previously was really hard to identify,
I mean,
because there's so many other things that could be going on.
yeah, endometriosis is really interesting for doctors. It's interesting, not so much for the patients. But I had a lady I did a hysterectomy on in her 40s, and I removed everything, and she had quite bad disease. And I post-op, because she was young, she needed to go into hormone replacement therapy. So I put her on a drug called Tibolone or Livio. I don't know if you have that over in North America. But it acts like HRT, but it's not estrogen based. So in theory, it shouldn't stimulate any residual disease. And anyway, she came back after 2 years with pain again. And I said to her, I don't think it's endometriosis. And I couldn't really give her any drugs because the ovaries had gone, so I couldn't downregulate her at all. And she'd had a colonoscopy and she'd had more imaging and nothing to see. And she went to the test and it was positive. And we did another laparoscopy, and sure enough, she had more endometriosis. So the difficulty is
Wow.
now know what to treat her, because you shouldn't have got the endometriosis on this drug Tibolone. So it's very
Wow.
useful. And there are other ladies who have had surgery. And as I said, probably about 30% of laparoscopies are negative. And I say to my colleagues, if a young woman subjected herself to surgery on a Thursday afternoon, do you not think she's got better things to do? She thinks there's something going on. And if they
Yeah.
don't find anything, why can't you find anything? You can't just dismiss these ladies because the laparoscopy is negative. You need to think about what else you're going to offer them.
So in Canada, we also have that public healthcare system, but it's really difficult. It takes a long time to get in for a laparoscopic surgery. About 30% of them in Canada are to investigate endometriosis. And of the 30% of all labs that are for endometriosis, about 20% of them come out negative. So they were actually surgeries that, women underwent that were unnecessary. Shocking, actually.
Well, so then the question that comes up is so David, if you have a young woman that comes to you and you do the test and it's positive and you think she's severe enough to go to surgery, if you were to go to surgery and initially see nothing, what would you do?
Endometriosis is really interesting because it doesn't come alone. the number of patients who have something called adenomyosis, which we really on the tip of understanding what adenomyosis is, but basically adenomyosis is where the endometrial tissue is in the myometrium, which is the muscle of the uterus. And often patients can have adenomyosis, but no endometriosis visible. But sometimes the subtle signs of the adenomyosis are missed at laparoscopy. And the endoscope test will pick up adenomyosis as well, which is great. So if you see a young girl who has got a negative laparoscopy, I would potentially put in a Mirena coil at the time of surgery because they may have adenomyosis. And I would also treat them with ovarian downregulation for a 3 months trial to see if they improve. Because if they've got adenomyosis, there's very little you can do about it, surgically wise, when they're young. So you have to treat hormonally. And the best way is with ovarian downregulation. I mentioned Rieco earlier, and that is now licensed in the UK for adenomyosis and endometriosis. So that's a drug I would put a young lady on until she wished to conceive.
Okay. So, and that's sort of like, it's not just birth control, basically. It's a daily pill. It's one, but it has everything, including downregulation, and hormonal replacement all in one pill.
Yes, it
I
does.
don't know if we have that. Pardon?
Yes, it does. It should be coming to the North America soon. It's basically got the ovarian downregulation, which was the same as the injections, the dectapeptide and things. And it's also got estrogen and northestrone in it. So it acts as a contraceptive and it's proving very effective. Unfortunately,
How are the symptoms of that? Are people able to tolerate it fairly well, or is it causing
um,
like some of the really negative mood symptoms, for
there's a
instance?
few ladies who've had mood symptoms with it. Of course, if they've got migraines, they're unable to take it, or if they've got underlying inherited conditions like factor V Leiden, which puts some risks of blood clots, they can't take it, or they've got liver disease, they can't take it. But there's a new drug coming out called linzagolic. It's another oral drug, an oral agonist. And the advantage of that is you can add in your own add-back therapy. So whenever you take in an agonist, ladies will get hot flushes, night sweats, menopause symptoms. But with a linzagolic, you can then use a transdermal HRT patch, which obviously bypasses the liver and is quite safe to take. So we're quite excited about that coming out.
Oh, that's interesting. Cool. Yeah, I actually looked this up. I'm a data analyst, so I looked up, this is explosive on the internet. This Rieco. It's really interesting. It's trending on Google Trends, which means a lot of people are looking that up and they're obviously looking for options when I see something like that. Because I like tracking these things from a different point of view, I guess. But yeah, I do see that. People have, I'd only found out about it actually, I think this week. So you're about 12 months ahead of me for sure. But yeah, it just sort of exploded out of nowhere. And I guess it just, women need these because they can't tolerate everything. You have to take the time as a clinician to encourage them. Let's find something that works. Don't just give up on it. And the more options they have, the more empowering it is to get this managed, basically, so their quality of life improves. I guess that's sort of the gold standard for you, is improving their quality of life.
It is. I saw a lady today in clinic. We did an extra NHS clinic today, and she was 37. She'd had 5 pregnancies, 5 babies, but she has a long-standing history of painful periods, discomfort with intercourse, abdominal bloating, general lethargy, and no one had really made a diagnosis. And the GP had sent her for a scan, and she got adenomyosis. But from a history, clearly she'd got endometriosis as well. Her GP had put in a hormonal coil, the Mirena, which had stopped her periods, but she's still got pain with intercourse. And I said to her, "You don't really know what normal is, do you?" And she says, "No." She says, "I've always had pain with sex. I just can't remember it never being painful. In fact, it's the stage now I don't really want sex at 37. I said, that's not normal, don't you? And she goes, I said, you just put up with it. And I suggested to her that she had a trial of ovarian downregulation to let her know what normality is. And another point I sort of wanted to make about other conditions, she'd also got recurrent cystitis. And when people hear the word cystitis, they immediately think, oh, infection. So often ladies will go to the GP with endo symptoms and cystitis, and they're often given antibiotics, which don't really work. And in the end, the patients give up going, they just drink loads of water and they get the symptoms. But a lot of patients will have something called interstitial cystitis or non-bacterial cystitis or painful bladder syndrome. And it's not an infection. Cystitis actually means inflammation. And there are so many women who have endo and this painful bladder condition, but it's very difficult often to tease out the symptoms. They just come with pelvic pain down there. And it just talk them through it. And you often find that they will say that any fizzy drinks, orange juice, spicy food, citric things will cause a flare of the symptoms. And subconsciously, they've often stopped drinking alcohol because that's another trigger factor as well. So these symptoms are very common. And certainly if ladies have a laparoscopy, I always recommend that they have a cystoscopy to check their bladder as well.
It is quite a pervasive disease, and I've always liked the terminology, the cancer that doesn't kill, because it just goes everywhere and plagues women so much throughout their lifetime and gets misdiagnosed for many things.
I can see why it gets misdiagnosed, because you may see a young lady who, is missing school. The GP starts them on the contraceptive pill and the periods stop. And then they hear no problems with their periods. Then they become a bit older and then they start getting pain with intercourse, discomfort afterwards. They get bloating and tiredness. And they go to a GP with bloating and they do an ultrasound scan. They don't really find anything. But what you should be asking these patients is, did the ultrasound scan hurt with the vaginal probe? And when you were going home afterwards, did you ache? Because that's a clear sign that there's something amiss, and it's usually endometriosis. But people don't think, because they don't have periods, it could be endometriosis, and they often get diagnosed then with IBS, and then they go around the circuit. There are patients I've seen who've been referred to the GI specialist. They've had colonoscopies and all sorts. They've gone to the chronic fatigue specialist, and it's clear because no one's asked them if they've got pain with sex. So you have to ask these questions.
In the patient-facing space, there's very little about cystitis, and it's just not well talked about what those symptoms are. I actually appreciated you sort of talking about what those symptoms are, because it's not covered well.
I mean, if you have painful bladder syndrome or interstitial cystitis, and I've seen ladies who've burnt their skin with hot water bottles. And whenever I see someone who's got this, what we call erythema abigne, skin on fire, they're in a lot of pain to have discolorated their skin. And it's usually because they've got this interstitial cystitis, because it's there all the time, whereas endometriosis in the early stages is only around period time. But the cystitis is there all the time.
Oh dear. Yeah. Wow.
And the other thing,
And it's a good lesson.
is that if they get referred to a urologists tend to do a lot of their cystoscopies under local anesthetic. And so they don't see it, because you have to distend the bladder. If you distend the bladder and then let the fluid out and then have another look, you can see all these little petechial hemorrhages, a little bleeding from everywhere. And some ladies, when they do the urine test, will get white cells and red cells, but there won't be any bacteria. And it can be intensely painful. So we normally advise using antihistamines. There's things like quercetin, dandelion root, pre-relieve, azo. There's lots of things you buy over the counter. And failing that, you're looking at some things like called bladder installations, where you put the protective layer back on the bladder.
Wow. Yeah, it would be just chronic pain that you'd have, and basically be doing anything to get rid of that.
Yeah,
Like
I mean, some people say subconsciously they've worked out what the trigger factors are. But the chief ones are really anything fizzy. You have Red Bull in North America, I'm sure, but that's a red flag, and
Yeah.
Pepsi and
Mhm.
cola. But Prosecco is really big over here, and that really irritates the bladder.
Interesting. Yeah, thank you for going through that because yeah, it is just not well covered. There's very little in the public space about that. And what percentage of patients do you think come in with cystitis
I,
together with endometriosis?
I would say in the younger ladies, probably about the 20-30%.
Wow.
So if you've seen a patient in the past who's got a diagnosis of endometriosis and then they present with cystitis symptoms, um, then they're very likely to have this non-bacterial cystitis.
Okay.
Um,
And then are these also the same patients when they do become sexually active? It hurts, like
it,
dyspareunia.
it can do. It's a bit like hand in glove. They're very commonly associated, but they don't always come together.
Okay.
But you should always have,
Which makes it fun for clinician, right?
yeah.
Which
So,
is nice, objective detection with a test as opposed to trying
so
to guess from
if you're doing
symptoms.
surgery and they've got any cystitis symptoms, I would recommend a cystoscopy at the same time.
I think this also goes hand in hand, something very important, and many young women will see the gastroenterologist. I myself practiced for a number of years, and I would say half of the young women coming in with uh, symptoms that we could never identify a cause for, I would send back to the gynecologist and tell them to go find the endometriosis. It's so common to have bowel symptoms associated with this, anything from constipation to diarrhea to rectal bleeding, which would be more severe. But just literally everything, irritable bowel. How many women have irritable bowel, David, who actually ending up with an endometriosis diagnosis after a mega GI workup?
Most of them have got endometriosis, but
Exactly.
the GI physicians don't tend to ask about pain with intercourse. As I said, they tend to ask bowel problems. So if you ask the right questions right at the beginning, and for some patients, if doing a symptoms questionnaire is a good way to start. I mean, having a colonoscopy is not fun, especially for a young person. Then doing a symptoms questionnaire would be the best way for a young woman to start.
Now, Dr. Griffith, how are patients finding you? Are they going to their family physician and being referred? Is it just luck?
Um,
Is it
yeah,
referral? What is it?
well, in the NHS, most patients are seen by their primary care physician, and then they're referred to the local hospital. A lot of hospitals will have endometriosis centres, and they were referred directly to them. The endometriosis centres really deal with the stage 3 and stage 4 disease, of which there's probably only about 10 to 15% at the most. But most young ladies don't have significant disease, but as we know with endometriosis, you can have minimal disease clinically, but be climbing the wall every month, whereas a lot of patients with stage 4 disease, they first present in our infertility clinics, and they've had no history of painful periods or pain with sex. And when you do an ultrasound scan, you see they've got large endometriomas. So it's really tackling the ladies who are young, really. And that's why the EndoSure test is really a boon for them, because you can diagnose them early to stop them getting to stage 3 and 4 potentially.
Yeah. That's what I'm really excited about for like my own daughter is let's stop that creep into an endometrioma or deep infiltrating disease and stop it and regress it even if it's possible. Do you think that's going to become possible for that patients can regress their disease or at least stop it from developing?
Well,
What do you think the future?
that's the whole thing with hormonal suppression. I mean, I've operated on a few patients who have done a laparoscopy and put a Mirena coil in, but the disease has been more extensive than I anticipated. So I brought them back to theatre in a few weeks' time, and it's just amazing. You've actually seen that the deposits of endometriosis have actually shrunk just with a Mirena coil. So hormonal suppression is certainly the best way to proceed initially. And then I would only do
And
surgery if their symptoms has not been under control.
the earlier that's done, the better. So if there were, let's assume there's thousands of women listening right now, when should they be bringing their symptoms to their primary care physician? Like, does it have to get to a certain level of pain? Is it when your over the counter pain medication stops working? Length of time? Like, what? How does an individual patient know? Hey, this is not normal anymore.
I think some of the pointers are if your mother had problems or your sister had problems, and they've been diagnosed with endometriosis, then you're a good candidate. Certainly, if you're missing school because the pain's that bad, or you have to use hot water bottle frequently, and you're really not being able to do anything during a period, I would go and see your primary care physician. A lot of women or young ladies come with their mom to the clinic, and they're not sexually active, but they're missing school at 14. They've got their we have GCSEs in the UK, so sort of the first sort of major exams for young ladies, and they're struggling, and I offer them. Normally, we offer them tranexamic acid and methylmenic acid, and for a proportion of ladies it will work, but those with endo, they don't tend to work too well. So then you offer something like a contraceptive pill, such as a progesterone-only pill. Some mums are very happy for them to have it, but you get a cohort of mums who don't want their daughters to go on the pill because of all the connotations that they're going on the pill and not sexually active. And I explained to them that when the contraceptive pill was actually designed, it wasn't designed for contraception. It was designed for period problems. And by chance, we found out that women did not get pregnant when they took this drug. And that's why it then became the contraceptive pill. And so they're much more understanding then of the daughters taking the pill. But if they're on the pill and it's not working, because you'll get a cohort of ladies who go on the pill, 15, and they'll stay on it and they're fine. And they'll stop it in about 10 years' time because either they want to give their bodies a break from hormones or they want to get pregnant. So they'll stop the pill, and then suddenly they'll start having period problems, pain with intercourse, and they forget they started a pill all those years ago, a decade ago, because they're actually missing school. And basically all the pills done over that time is suppress it all. And then you'll get another cohort of girls who go on the pill, and it doesn't work, so they'll try another one, then they'll try another one. And they've tried several pills before they end up seeing a specialist. So say with the Endometriosis test, if you get an early diagnosis, at least they know what they're dealing with. Because when you read social media and the internet about endometriosis, I mean, the first thing which flags up with people is infertility. And of course, if you're a young lady, these days, ladies are leaving having babies till later, and they want to know, if it's going to affect their fertility. So it gives them options. Certainly in the past, I've seen older ladies who were misdiagnosed and they're in the late 30s, and they're just so upset, but they didn't get an earlier diagnosis.
Yeah, it's basically silent until they want to achieve pregnancy. And it's this stats that I've read are something between 30 and 80% of women with infertility have endometriosis. They might have PCOS as well, combined, but it's really helpful to know that you have endometriosis, because that can change the way you're treated, I assume. Like, there are some things like a lipoidal flush, for instance, that can be done immediately if you have endometriosis. So it's an HSG, hysterosalpingogram, but you use a lipoidal, which is poppy seed, instead of saline solution. And for some reason, about 50% of the women get pregnant. But you wouldn't do that normally unless the person had endometriosis. They're doing that in Australia. I found that very, very interesting. It doesn't mean that all the other modalities aren't needed, because there's many who don't become pregnant or they miscarry. So,
Isn't it quite controversial still whether endometriosis without ovarian involvement truly does affect fertility?
Um, yes, it is. I mean, a lot of ladies get pregnant with endometriosis and never knew they had it. Um, and it's only sort of after they've finished their family that it comes to the fore. The number of times you see women come in and they've had problems for just a couple of years, and it coincides with the time that they stopped their contraceptive pill because their husband had done the right thing, so to speak, and gone off for a vasectomy, so they didn't need to use hormonal therapy anymore. And suddenly, um, their problems have all come out to the fore again. You see that quite frequently.
Wow. Okay. I'd never actually even thought of that group, but yeah, that makes perfect sense where you'd be surprised suddenly you'd be in pain. So it's actually something to watch out for.
Mm.
You see these patterns, I guess, as a clinician.
And so these ladies end up having some kind of hormonal therapy like the Mirena coil.
Yeah, very good. We have about 5 to 10 minutes at most left. Mark, did you want to ask? Like, I'm actually really interested in these trials that you're starting out because using the EndoSure test both before and after treatment to actually develop therapeutics that we can say actually treat endometriosis. Because everything I read, the first statement is there is no treatment for endometriosis. There's only treatment to reduce symptoms. So studies in this area could be very powerful.
Well, this is why
I
David's early findings are so important, is to see it's so impressive to see not only the values go down, the measurement values for the activity index of the disease, but to see the symptoms go down with it. And so over time, as we get more and more of these patients, and when David publishes results, the pharmaceutical industry is going to be very interested in having this type of a test to measure the effect of what happens with their drugs. I think it will, David, I think it will open up the door to many, many new treatments coming out that may be waiting.
There are several in the wing, um, but it's nice that you can show that, I say, there's objective improvement with the patient's subjective improvement. Um, and a lot of the ladies on the drug, they don't want to stop it. But before, I mean, it's a combination of the EndoSure test and the new drugs, which is going to change the management for many of these young women. I mean, I've got 4 daughters, and I put 3 of them through the test. 2 I thought had endometriosis, and they did. And my other daughter, I thought, had another gynae problem, which you alluded to earlier on, PCO. Hers was negative, as I expected. So I asked I forwarded the results to my daughter's GP, and they started her on the pill. She's seen an improvement. I think part of the problem in the UK is it's still fairly new, and so there are a lot of people have not heard about it yet, about the tests. Patients are probably finding out quicker than GPs are at the moment. So it's important for us to get the message out there that this test is available. I think
Yeah, that's what we're
It
really
is
looking for
wonderful.
as well.
there's about
Sorry,
Yeah,
keep
it
going.
is wonderful to have an alternative to make your diagnosis.
I mean, but there are in different clinical cases, like the ladies who've had the laparoscopy and told it's negative and go away. There's nothing there. So those ladies, it's really beneficial for the ladies who are young, who I would not send for a laparoscopy. It would be very beneficial for them. Ladies who've had surgery for endometriosis and they've got pain again, rather than subject them straight to another surgery, you might need to do the EndoSure test again. Some of the NHS trials, I think they're looking at pre and post surgery to see how effective the surgery is. Because often you'll find patients have surgery and say, oh, we're fine for 6 months, then it comes back again. And you do hear stories of young women having repeated surgeries. And, you
What
know,
about the ladies who are postmenopausal, David,
oh,
who
that's interesting.
are fine?
That's very interesting. You do see postmenopausal endometriosis. It's really quite difficult to treat. Um, I do remember a lady once, she was 16, she got discomfort with intercourse, and the GP had done all the normal things. She'd been with her husband a long time. But she suddenly started to develop pain with intercourse. So he assumed that she was dry down below, which happens with age. So he gave her some estrogens. That didn't help. Then he treated her for herpes. She was a bit shocked, but because she'd never been without anyone apart from her husband, and that didn't work. So eventually he sent her to me, and I said, well, she'd never had any period problems in the past. No, nothing. So we did a laparoscopy on her and took some biopsies. She's got endometriosis. And you do see it sometimes in ladies. You operate on postmenopausal ladies taking their ovaries out, and you can see they've still got endometriosis there. You can see old endometriosis. So it's probably the older generation probably just got on with it with a hot water bottle and didn't complain. Whereas now we know that they probably had endometriosis as well.
Interesting.
Well,
Do you see a
it sounds
group
like we
like
have a lot of
coming
use.
in? Yeah, I was also gonna ask about things like I have a lot of friends with fibromyalgia. That's a thing in Canada anyway. And it was really just unexplained pain. What about doing a scan or test on patients like that? Because it's really unexplained pain in women.
I mean,
So,
there is an association with endometriosis, adenomyosis, interstitial cystitis, fibromyalgia, Sjogren's, where the ladies have dry eyes and dry mouth, irritable bowel, lupus. There are lots of commonly associated conditions. I see quite a lot of patients with EDS, Ehlers-Danlos syndrome, which is like hypermobility, joint dislocations. And a fair few of them also have endometriosis as well. So it's sometimes difficult to tease all these symptoms out. And with fibromyalgia, I often see, 'cause I've been doing this a long time now, you see patients who get treated for endometriosis and adenomyosis and cystitis, and they come back and you see that in their notes later on that, they've been menopausal now, and along the way they've been seeing a rheumatologist and they've been diagnosed with fibromyalgia. Some ladies are unlucky enough to have fibromyalgia at the same time as endometriosis. But there's a lot we still need to understand, still a gaping gap in our knowledge. Um,
yeah. That's very good. Hey, as we close this, just because we're almost at 45 minutes, what is like the main take home message you would want to send to women who are in pain, maybe especially your area of specialty in cystitis and urology, about what they should be doing to take care of themselves and how they can access help? Do you have like a central message you want to send out?
I think it's important, if you feel that things are wrong, that you go and see your primary care physician. And if you think that you have endometriosis or this interstitial cystitis, see what your doctor says. And if they don't come up with a conclusion or possible diagnosis, just say, do you think this is endometriosis? Do you think this is interstitial cystitis? Because the doctor may have not have thought of that, and ask to be referred to a specialist who can help you.
I think it's important to just never accept no as an answer. You feel your pain. Something's wrong. There's an answer somewhere.
Yeah, and as I said earlier on in this podcast, I said, if a lady has a negative laparoscopy, why she got a negative laparoscopy? Is it because you didn't see something, or was it just not visible? Because who's going to subject themselves to a surgery? 19-year-old girl's got better things to do on a Thursday afternoon than have surgery.
Right.
Yeah, she really doesn't want it if she doesn't have to have it. Yeah. Yeah. Thank you so much for coming on our podcast. You've provided some contact information. We'll put that in the show notes for everyone. And we hope to have you on again. Have a great Sunday, Dr. Griffiths, and thank you for coming on.
Thank you, Carolyn. Thank you for inviting me.
Thanks very much, David. It's been wonderful.
Thank you, Mark.
And that ends another episode of Endometriosis A to Z, where we feel knowledge is power when it comes to managing endometriosis. We'd love to hear from you about topics you want covered. If you have questions that you need Dr. Noir to answer, you can email us directly at hello@endodiagnosis.com. Until next time, stay informed, stay hopeful, and keep advocating for your health. See you in the next episode.